We're delighted to have Sarah Bracken, the Health Information Lead from Tommy's Pregnancy Information Team. Sarah manages healthcare professional outreach, helping clinicians access reliable, evidence-based maternity information and supporting women and families with practical online resources and tools. Sarah's going to talk about, the more sort of standard preconception care, which is obviously an important part of the picture. So please welcome Sarah Bracken. Thank you, Sarah.
Thank you, everyone. I hope everyone at the back can hear me. So thanks for having us here today. I have some of my Tommy's colleagues in the audience. Probably with my slide here. You can see our pink stand, lots of pink. So yeah, I'm the information marketing manager. I lead on the outreach, if you like, to healthcare professionals. So we go to conferences, events, and work with Black grassroots organisations. So we have our information side of the team, and then myself and Nia here are here to raise awareness of what we have, our tools, our information, which is PIVTIC accredited. And I just want to take you through our planning for pregnancy tool today. I have actually just done it a couple of times this morning, so I really encourage you to go on and just get used to how it works yourself. It takes just sort of 5 to 10 minutes. And then you can sort of really get to grips before you start signposting it on. It's a really good way to get to grips. Anyway, let's skip ahead. Quick show of hands, who's heard of Tommy's? That doesn't include Tommy's people. Oh, fantastic. My work here is done. Yeah, we're the largest UK charity. When we go to conferences, we get a lot about, are you Tommy TP? Are you Tommy's? Are you Tommy Hilfiger? No, we're not. So yeah, you know us, so we won't go into too much detail, but we are here to stop the heartbreaking devastation of baby loss, make pregnancy and birth safe for everyone. So we have lots of research centres across the UK. Here are our 4 key ones, and we fund over £2 million in research every year. So every bit of fundraising that happens goes straight into the research to improve care and outcomes for mothers and babies. The model is straightforward. We translate the findings into information. We make sure the tests, treatments, and new models of care reach families nationwide. And we advocate for change from the government. Again, all so we can save more babies' lives. And at the bottom, these are our 4 organisational objectives: to grow evidence through research, to tackle inequity, mobilise for change, and to improve care. So I won't repeat the first 2 points there, but as I said, we have an in-house team of Tommy's midwives, some of whom are here today. They provide support to women and birthing people who call our helplines. We have a general helpline that anyone can call Monday to Friday, 9 to 5. And we also have our Protectors helpline, which is for Black and Black mixed heritage women and birthing people, which is a bookable service online. Oops, just bear with me. Where's the mouse gone? There it is. So the helpline is focused on proven outcomes, so we can support people with behaviours, as well as referrals if it's relevant to their personal situation. We maintain and develop health information on our website. I don't know if you've used it, hopefully you have. So that everyone has access to the most up-to-date information on preconception and has a healthy pregnancy. And we have about 400 pages of content, which is a lot to review for our content team. And we had about 10 million views in 2024. So it's a very well-used website. So a bit on why preconception health. I feel like I don't really need to say that because it's been said a lot today and people understand, but we are involved with health before pregnancy. We used to think our work started when people were pregnant, but then the evidence started mounting that what happens before pregnancy, as everyone has said today, is just as important. And you've heard a lot today about the relevance of health behaviours and risk factors for poor outcomes, both for the baby and the mother. And these behaviours and risk factors are established well before you become pregnant. So as a result of this, we thought, we really need to do some research and develop a tool into planning for pregnancy. So just moving on. Actually, have you all read this slide? Because it's got some quite important points on there. But 1 in 4 adults fail to meet guidance for physical activity, and folic acid. A lot of people, when they become pregnant, myself included actually, didn't take the folic acid beforehand. It started the day that I got a positive test. Luckily, everything was okay. But we did quite a lot of interesting vox pops. If you go onto our website, onto YouTube, we're going up to people in the street saying, they plan for a holiday, they plan for a new job, they'll plan for, their wedding, but no one plans for getting pregnant. So the importance of health in the preconception period is not well understood by families. So for most people, as we said, it starts at conception, so it's changing that behaviour or going to seek GP advice if you need to. If normally what happens is people will have difficulty conceiving, and that's the point where they go to the GP, not, I'm thinking about getting pregnant, what could I do better? And then there are lots of different public health messages, so it's a bit of an information overload. People aren't quite sure what they should do, so, they probably switch off a bit. And then also in the GP appointment, primary care providers, it's very difficult to get all of this information across in one appointment. And if someone doesn't disclose that they're trying to get pregnant, you won't be able to do that anyway. So it's sort of trying to capture ways that we can get the information across beforehand. Bit on behavioural insight. So the research we carried out before we created this tool, which I'll take you through in a minute. Once we explained the concept of preconception health to people, the idea actually of taking steps before conception to maximise your fertility and the chance of a healthy pregnancy was of really high interest, perhaps unsurprisingly, and women were really keen to find out more. And our own research was backed up by local insight from South East London, ICB. Thank you for that mention. And who we worked with on a campaign, they'd had similar results. The barriers were shown as limited preconception information access versus a clear desire for it, and a real interest and willingness to engage sort of remotely and online. So this little screenshot over on the right-hand side is what the tool looks like, your results. I'm going to hold up my phone in a minute and show you what I got. I got lots of orange and lots of yellow. Orange is about things that sort of slightly risky, I was going to say risky behaviour, that doesn't sound right, but risks that you should address if you want to have the most positive outcomes. Yellow are things to think about, and then green, which I got none of just now, but I did pretend to be someone, are things that you're doing really well. So, planning for pregnancy tool. This is how it will look on the phone. It's free, easy to access. As I say, I just did it just now. I haven't done it for a while. It took 5 minutes to go through the questions. Actually, there's only about 10 questions. It's all tailored, so depending how you answer that question, it will then serve a different question. So everyone who does it will get completely different outcomes. You'll get the basic questions, but depending how you answer, for example, you might say you are in that older age bracket, you have sickle cell disease, you've had previous loss, you smoke, you have like all the associated risks, high BMI, drink alcohol, take recreational drugs. Then you will probably get a lot of oranges coming back saying these are things that you need to consider. Everything that we offer at Tommy's is free information. So we encourage everyone to sort of signpost, and it's a very user-friendly tool to use. And as it says here, it aims to deliver key health messages before conception. So just a little bit on the user journey. There are 4 steps essentially. Great, love it when it works. The tool starts with a questionnaire. So the user is asked a series of questions about their health and their behaviours. And then this data is then gathered to give their tailored results, any potential risks to future pregnancies and the health of their child. And as I said, it's a bit of a traffic light system with the orange, the yellow and the green. what they might want to focus on, what they may want to think about. It's all done in a really supportive way. It's really supportive language. It's not, there's no sort of blame, accusation. It's really, really nicely done. And each risk area that comes back then it signposts you to further information on our website. Or to other resources, for example, Sickle Cell Society and Thalassemia, who are here today. And then the user is then offered a series of supportive follow-on emails from Tommy's to help them on their preconception journey. These will be tips and advice. Again, it's all personalised to the user's answers. And then if you are a Black or Black mixed heritage woman or birthing person, you are offered automatically the chance of a one-to-one midwife call. That's our Black and Black mixed heritage helpline that I mentioned before, and we have it on our stand if you'd like to take away any cards to hand out to women in your area. And then, yes, here we go there. The tool itself, although it's in English, the information that we have here is available in 15 languages. So if you wanted to sort of print them out or display them in your hospital or your healthcare setting, you can do that. We have them in all sorts of sizes. So please come and see us and take away whatever you need. And you can translate it within the tool into about 103 languages. There is a disclaimer. It is AI. It's Google Translate. It's extortionately expensive to translate a tool into individual languages. So that's the way we do it, and it has a disclaimer to check this advice with your local healthcare setting or interpreter. So it was originally launched in 2016. We have done extensive work on it to bring it up to date all the time. And we have consulted with many groups, Black grassroots organisations as well, that we work a lot with, for example, 5 Times More, the Motherhood Group. So all the health information has been fully reviewed and up to date. We listen to feedback especially from Black and Black mixed heritage women, about the questions that were asked, how they were asked. So we take ethnicity into account when calculating the BMI thresholds, but you don't have to answer that. It's not mandatory to answer that if you prefer not to. Improved mental health information, a new vitamin D intake information, and improved pathway for pre-existing physical health conditions that we've spoken about a lot today. Great. Actually, I'm not coming to the end, but I'll whiz through quickly. Let me whiz through. These are the topics covered. I added them up. I think it was somewhere around 17, 18 different topics. So we do try to cover anything. If you see there's something there that you think should be, please come and let me know. And just a little bit on the evaluation. We did an evaluation to see what users thought about it. And this is 109 users that came back. As you can see, 76% found the tool useful, extremely useful. Only 3% didn't learn anything new. And that might be because they knew already, which is fantastic. But a massive 97% were reminded of a health message or they learned something new. Would you change your behaviour? Again, a really positive response. Only 8% wouldn't take any action. So the rest would make changes such as behavioural change, uptake of recommended supplements, or reaching out to a health professional to discuss any issues. Confidence and empowerment, 57% increase in advocating for yourself, which is fantastic, and your ability to speak to healthcare professionals. 54% positive effect on mental health and well-being. And some qualitative feedback, great tool, keep up the good work, very informative, free and helpful advice, helpful, simple, straightforward. And then some interesting feedback on tips from male partners. That's very important too. So everything that we get, we take it back and we think, right, how can we feed this into the next iteration? So if you also have feedback, we'd love to hear it. And just a quick on the support available from Tommy's. As I said, we've got lots of printed materials here. that you're welcome to come and take away with you today. But we have worked with South East London, who had some budget to do the things that are listed here. So as I say, we've got 15 translations that are downloadable on our website, which is of what you see on screen here. So the top tips and the QR code page. But with budget, you can have extra translations, social media campaigns, targeted poster campaigns in community spaces, particularly where you want to reach. Webinars, we do webinars for healthcare professionals to go through like what you can get out of this and how you can promote with the patients in your communities. And we can also, as you can see here, provide the anonymised data so you can see what you need to do and where. And that is.
And so next, we've got Neve from Unique, the Rare Chromosome Disorder Support Group. So Neve supports families navigating rare conditions, explaining test results, connecting families with shared experience, and represents Unique in lots of events and forums. So please welcome Neve. Really pleased to have you with us today. Thank you. So it's just this one.
Oh, can we use the clicker?
Yeah.
Oh.
So yeah, I'll just do a really quick introduction about me and what my role is at Unique. So I am the Scientific Communications Helpline and Family Support Officer. My name's recently been changed, so now it's a bit of a mouthful, but that's what I do. I offer emotional support and practical information to families and professionals, either by phone or email on our helpline. But I also write the Unique guides for a range of audiences as well. I'm a registered genetic counsellor, and before that, I taught science at a special needs school as well. So I'm going to do a very quick biology lesson of what a rare genetic condition is. So essentially, we're all made up of billions of cells, and inside each of those cells, we have our genetic information called DNA. Our DNA is like an instruction manual written in a 4-letter code, A, T, G, and C. And along our DNA, we have our genes. Our DNA is packaged into tightly coiled structures called chromosomes. You can imagine chromosomes a bit like a recipe book, and then your genes are like those individual recipes in those books. We have 2 copies of every chromosome, and that's because we get one from mum and one from dad. And people can have changes in their chromosomes. So these can be part of your chromosome missing, part of your chromosome having too much of it, or in the wrong place as well. You can also have much smaller changes, such as in your genes, and this can be things such as a letter being in the, change from a G to an A, for example. Regardless of these changes, it may impact growth, learning, physical development, and health, meaning that many children with rare chromosome or gene disorders may be affected with learning disabilities, physical disabilities, or medical complexities. So what are the reproductive options for families with a known rare chromosome or gene disorder? I think regardless, deciding whether to have another child is a huge decision to make. And our Unique families have the added complexity of having to work out how another child would fit within their family dynamic as well. But overall, I think families want to know what their chances are of having another child affected with the same condition so that they can either prepare or reduce the chance of having a child affected altogether. So that's where the reproductive options come in. So before pregnancy, there are 4 main options. The first is pre-implantation genetic diagnosis. And this is essentially a special type of IVF. And once the eggs have been collected and fertilised, they are monitored for a few days, and then those embryos are tested to see if it carries the same gene change. Only embryos without that gene change are then implanted back into the womb or frozen for later use. Importantly, PGD only has about a 30 to 40% success rate, and that's because the amount of viable embryos sort of halves at every point in that process. There's also very strict eligibility criteria for this on the NHS, things like the female partner has to be below a certain BMI, neither parents can smoke or vape, and they can't have a child who is unaffected as well. Because of this, early referral to PGD services is really important so that they can get that ball rolling as soon as possible. The next possibility is egg, sperm, and embryo donation, and the mixed with IVF. And the HFEA has a really good resource for couples who are considering egg or sperm or gamete donation. The next option is adoption. So lots of families who are interested in adoption can go to their local council adoption agency. Adoption UK also has a brilliant resource, and we actually also have a guide on adopting a unique child as well. The next option is do nothing, have a natural conception, and once you're pregnant, have sort of things in pregnancy to see if your child may carry a gene change. So I'll go into this in a bit more detail. So prenatal testing options, I'm sure you guys are well aware of all of these, but I'll really quickly whiz through them. So the first is CVS, chronic villus sampling, and this is where a sample of the placenta is collected and tested for the gene change. It's normally performed around 11 to 14 weeks, and it does carry a small risk of miscarriage. Next, we have an amnio, and this is where a sample of the amniotic fluid is taken and tested. This one is performed from 15 weeks, and again carries that small risk of miscarriage. Next, we have NIPT. It's important to remember, as you know, this is a screening test. So any positive result from the NIPT will then have to be confirmed through the more invasive methods as well. But this essentially is a sample of maternal blood collected and tested for I think it's three most common chromosomal changes. So trisomy 13, 18, and 21. Because of this, a lot of our unique families who have very rare chromosomal changes isn't really covered in this test. But it can be performed from 10 weeks, doesn't carry a risk of miscarriage as well. And it's a screening test. The next one is non-invasive prenatal diagnosis. So this is slightly different. It's still a sample of maternal blood collected, but it can be used to detect specific gene changes or chromosomal changes. So it's particularly useful when testing to see if the pregnancy carries a gene change inherited from the dad, because essentially if it's in the blood and mum doesn't have it and it's there, it means it's been inherited from dad. It can also be used to assess the risk of autosomal recessive conditions and can be used to determine baby sex as well. So what next? So once you have decided to go ahead with pregnancy, or you want to find out more information about, rare chromosome and gene disorders and things like that, I imagine that there will be lots of questions. And I think finding out this information, it's not always bad news for families. And I think it's important when discussing, prenatal diagnoses and things like that with families, it's important to sort of feed off what the energy they're giving, I guess. Because, it's not always bad news, but I think no matter what, a lot of parents are always like, well, what next? What do I do now? And that's where charities like Unique come in. So we are a charity for those affected with rare chromosome and gene disorders, normally associated with developmental delay and intellectual disability. Our main three ideals are to provide information to our family members, create a network for families to be able to share their experiences, stories, and advice and things like that, and to support, so provide the emotional and practical support to those families. Overall, though, our aim is that together we will beat the isolation of rare chromosome and gene disorders. This slide sort of gives a bit of a snapshot of, our membership and our reach. So we have about 32,000 members at the moment, with 150 to 200 new members every month. So we're a very small team, but supporting a wide number of people from around the world. And this slide just sort of shows our numbering of our top 10 countries around the world. So what do we offer families? So our charity is sort of split into two, I guess. So on the one hand, we have information and signposting. So we have our information guides, which provide very detailed information to families about what to expect for their rare chromosome or gene disorder, you know, what symptoms there are and what your life might look like with that rare chromosome or gene disorder. We also produce practical guides for sort of everyday advice on, you know, everyday things, toileting, education, things like that. We have our database, which is a huge amount of information, basically, of symptoms, learning, developmental aspects, and any medical information as well from our members. We also have our magazine, which is a place for updates for our families of research, and it can also, I believe, be sent out to professionals as well if you wanted to sign up. On the other side, we have our emotional support. So one of the key things that we do is we share contact details of our members with people with the same condition or in the same area. And this just gives you, you know, the emphasis that you're not alone. You can share information and support and advice with other families going through the same thing as you. We also, as I mentioned, have our helpline, and this can be used by both professionals and our members for any questions or concerns. We have our family days and events. Last Saturday, we had our 2026 conference in Birmingham, but I think it's a really good way to, you know, connect people with professionals, share education, but also give our families a fun day out as well, which is lovely. And finally, we have community and belonging. We really try and create the sense of community. And I think one of the examples of this is our Facebook Cafe, which is a private group that our members can use to air out grievances and ask questions and you know, share their stories as well. So I'll go into a bit more information about our information guides. I have to try and get the numbers up or I'll get in trouble. But essentially, our information guide project was created back in 2004 to address a big gap in the accessibility. So a lot of the literature back then was quite negative. It was focusing on the worst case scenario and written in very complicated, medically complex language. So we wanted to create guides that were not only truthful, but also easy to understand and gave you a realistic idea of what your life might look like. So that's where our guide project came in. Now we have, give me a moment, over 300 information guides, 80 single gene disorder guides, 550 translations into 22 languages. We have our practical guides, which I touched on, but we also have My Chromosome story booklets, which is essentially a storybook used by children with rare chromosome or gene disorders, their siblings, their friends, to be able to have a way of communicating their rare chromosome and gene disorders as well. We also have our easy read guides, which are used by teenagers and adults with learning difficulties, to be able to put in really simple language, you know, what their rare chromosome or gene disorder means. Just to highlight, two of our practical guides are prenatal genetic testing and diagnosis and planning your next child, which seems to be quite important for the work you guys are doing. We're back. How our information guides are used, it gives a clear overview of what might happen over time for our patients and professionals. It gives practical suggestions and tips based on real experiences. It's a reassurance they're not alone. You know, they've got lists and testimonies of families in these guides. And it's also validation that their or their child's condition exists and it's real. A lot of the time, families have waited a long time for these diagnoses, and half the time they'll go to professionals and they'll be like, I have no idea what this is. So it's just validation that it is real. It's also a useful tool when working with professionals because we work with professionals to create those guides. So it is also written in the language that professionals, accept and things like that. And it's been used in tribunals to get that education support as well. Our problem is that we have too many variations and not enough time. So we have thousands of variants and gene disorders, and there's only 3 of us in the guide team working on these. So they take months to produce one guide, let alone how many there are. So we're always working on new projects. We're always looking for volunteers to write some guides, and things like that, just to try and produce it as quickly as we can. But bear with us. So what can we offer you guys? So there are a few different things that we can offer. Our information guides are just as useful to you as they are to our patients and our members. We have anonymised phenotypes, which is symptoms. So you can contact us if you have a family member, if you're managing a family with, say, a 17p duplication. You can go to us and say, have you got any members with the same thing? And then we can send you over anonymised symptoms or development information and things like that to try and give your families an idea of what they can expect. We sit on a lot of professional initiatives and advisory boards to sort of be that patient voice. And we work alongside other organisations as well to sort of really create that community and one voice for people with rare chromosome and gene disorders. Finally, awareness raising and education. So days like this, where we come in and speak to professionals and try and raise the word for unique and rare chromosome and gene disorders and things like that. What you can do for us. So follow us. We have lots of information on our Facebook, X, it's not Twitter anymore, Instagram and YouTube of things we're doing and events. It's Rare Chromosome Day coming up in June. Contact us. If you've got any questions or concerns or want to refer a patient, use our helpline and donate, please. We don't run on any government funding, so we rely very heavily on the kindness of people. So yes, that's mainly what we can do. And yeah.
Hi everyone. My name is Jenny, and today I'll be talking to you about Preconception Precision Health in sickle cell disease, and thinking about moving from reactive pregnancy care to proactive reproductive planning. When I was told to talk about this, I was supposed to talk about hemoglobinopathies as a whole, so including my thalassemia team that are over there, as well as the sickle cell, but I was like, oh, it's just going to be too much, so I'll concentrate on sickle cell today. Hopefully there'll be other times for me to talk about thalassemia, but those two things are quite dear to my heart. So my objective today will be to talk about why sickle cell disease requires preconception and health, the key inequities that we see in the reproductive pathways, maternal risk and the case for early optimization, as well as practical actions for the primary, community, and specialist care. So concentrating on genetic risk, reproductive planning, maternal health, and equity in the practice. So why am I talking about sickle cell disease today? I tell people sickle cell is not going anywhere. There's a global burden. So approximately 7.7 million people live with sickle cell globally, and there are approximately 515,000 new births annually. Coming back home to UK, in UK alone, we have approximately 17,000 people with sickle cell disease, and there are 300 babies born every year. And then among those, the normal births, we have 1 in 79 babies born in the UK carry the trait. So I did the calculation based on how many births we have every year. And that means that there's 7,528 babies born every year with the trait of sickle cell disease. And London holds half of the England's sickle cell population. And of course, we know that there's been lots of migration, there was trade route, there was the Atlantic slavery, and this has spread the gene globally. 25.6% of people in England and Wales are not white British. And most of these people that have come from communities that have high hemoglobinopathy prevalence. So every clinical setting will encounter either sickle cell trait or sickle cell disease. So sickle cell is common, inherited, and present in every health system. We also have like high acute care demand. So the London ambulance responds to approximately 6,000 sickle cell related 999 calls every year. And the hemoglobinopathy centers in London alone treat approximately 10,474 patients. And this gene, like I said, is not going anywhere. And this is because the sickle cell trait protects against malaria in malaria endemic regions. And because of this survival with malaria, then there is high frequency, more carrier couples, and more children born with sickle cell disease. So high prevalence is evolutionary and not behavioral. Also, sickle cell disease is a chronic multi-system condition, so it affects every area of the body. I don't think we can see that diagram very clearly, but it's almost like a head-to-toe kind of thing. There's some chronic complications, acute complications. There's also increased high pregnancy risk because of the multi-system complications. You can have vaso-occlusive crisis, infection, sepsis, stroke, chronic pain, and organ damage. Sorry. So pregnancy in sickle cell is quite a high-risk setting. So there are approximately 110 to 200 pregnancies in women with sickle cell disease each year in the United Kingdom. And pregnancy in women with sickle cell is associated with higher maternal mortality and morbidity. And some of the risks faced by these women include the vaso-occlusive crisis, infection, thromboembolism, preeclampsia, that's high blood pressure in pregnancy. Babies are born preterm. There's fetal growth restriction. I was looking at an article yesterday, and it says they also have like high risk of miscarriages as well. So what do we do for women when they already have sickle cell disease and they want to have babies? So we can optimize their care by doing medication review, preconception folic acid supplementation, vaccinations and infection prevention, so putting them on prophylactic antibiotics, assess the organs to make sure they don't have any issues on there, and of course, multidisciplinary planning. So this is about maternal health, and it's just not just genetics. So why does the Preconception Precision Health, why does it matter in sickle cell? We find that pregnancy is too late for first conversations. Early planning creates time to understand these genetic risks, explore reproductive options, optimize maternal health if the woman has sickle cell disease, and prepare them emotionally and practically. So when we start these discussions only when they are pregnant, we narrow their options and the inequity widens. So what does good care look like? I think we've talked about this quite a lot this morning. So explaining inheritance and reproductive risk clearly, offer screening proactively and ensure equitable access, document genotype and carrier status accurately, refer early to clinical genetics when indicated, revisit these conversations over time, especially in young adults, of course, including men in this counseling and decision-making, exploring all reproductive options without assumptions, and normalizing preconception discussions across the pathway. So we need to make the care routine and not reactive. Whenever I talk, I always talk about inequalities in sickle cell care, and I was talking to Dominic earlier on, and I talk about this all the time. Things haven't changed. We're still hoping that things will change. So I have done a talk before, and it happened that one of my lecturers was in that talk, and she was like, Jenny, can you stop comparing sickle cell disease with CF? But I'm not doing a comparison. I'm just trying to get people's attention for them to look and just see, just have an overview of what is actually going on when we talk about inequalities in sickle cell care. So sickle cell disease, there are 17,000 people affected in the UK. Cystic fibrosis has 10,800 people, so not that much different. So it has similar prevalence to cystic fibrosis. But for sickle cell care, specialist nurses, they have 0.5 specialist nurses per 100 sickle cell patients, whereas in CF, there is 2 per 100. There's 2.5 times more research funding for cystic fibrosis, and there's only 2 approved therapies for sickle cell disease. They also experience high acute care demand, negative experiences, especially when they go to our emergency department. So the inequity is not because of because it's a rare disorder, because CF also, but it's because of there's an underinvestment in sickle cell disease. There is also inequity in the reproductive pathways, so information often arrives too late. So we're meeting these families when they're already pregnant. There is no routine non-invasive prenatal diagnosis for sickle cell disease. It's available for other monogenic conditions, so like SMA. And there's been talks about the barrier being because it's technically more complex, and of course, commissioning requirements. And then access to pre-implantation genetic testing for monogenic condition varies by region. The high prevalence communities often face the greater barriers, and of course, men are often excluded from these discussions. So the inequity is driven by system design and not by patient choice. Equity is about when, where, and to whom those options are offered. So this picture, I really like this picture. So in the first one about equality, yes, we're providing the same thing for the people there, but it doesn't work for all of them. So in terms of equity, it's about providing things that will actually work for the people. So these inequities, they are not abstract. They show up in real families, in real pregnancies every day. So I'm going to talk you through a case study that I met in practice. So I met this lady, sickle cell, she had sickle cell, and her partner, who is a carrier. I met them after they had a baby. So because the partner is a carrier of sickle cell gene and she has sickle cell disease, they had a 50% chance of having a baby with sickle cell disease. When she was cancelled, she was already pregnant. She declined prenatal diagnosis. And of course, we all know because of the miscarriage risk, a lot of people tend to decline that. Her baby was born with sickle cell disease. She had a very complex birth. She was in hospital for long. She had blood transfusion. She had IV antibiotics. She was quite unwell while she was in hospital. I met her after she had the baby. So as part of my role, I was to go to her house to tell her, your baby now has sickle cell disease. So I went to the house, and of course, she'd never heard about pre-implantation genetic testing before. And it kind of bothered me because it just raised 2 important questions. Did we meet this family early enough? And are we using prenatal diagnosis as a moment of choice or an opportunity for preparation and support? So most of the time when we're offering PND, are we telling them, oh, okay, if your baby is affected, are you going to terminate the pregnancy? So that is like the option we're offering them. And a lot of them don't want to go through termination of the pregnancy. So why does this case matter? So when I met her postnatally, key information was missing. She wasn't sure of her exact genotype. Her partner did not understand sickle cell disease. Their reproductive risk had never been clearly explained to them. So we found that we are playing catch-up. Conversations that we're supposed to be having before pregnancy was happening after she had the baby already, creating urgency where there should have been time. So it was after she had the baby, I started telling her, oh, there's an option of pre-implantation genetics. In fact, I told her, I said, please, don't have another baby without telling me. And she was just laughing, but she's had a baby that already has sickle cell, so it already putting pressure on the family as well. So this is what reactive pathways look like. Families are making decisions under pressure. Professionals are trying to catch up. And opportunities for preparation and choice is lost. So this case is not about her decision. It's about whether the system met her early enough. So did she already know about all these things before she decided to have a baby? So if this is what happens when conversations start too late, what should the right pathway look like? What should we be telling these families? So we should actually be discussing options about preconception during sickle cell annual reviews. If a partner is identified as a carrier, in-transition clinics, so young adults talking to them about it, men with sickle cell disease or traits, as well, because I have a case study also of a man that has sickle cell disease and had a baby with a lady that is a carrier. So she probably didn't understand, and he as well. At any opportunity in their healthcare journey, we should be having these conversations. When discussing medications with reproductive implications, so like hydroxyurea, we need to be talking about this preconception. And when a patient expresses uncertainty about future family plans, so these are questions we should intentionally be asking them. So some of the reproductive options, I think some of the earlier speakers had already talked about that. They can decide to go for natural conception and have prenatal diagnosis. They can decide to go for pre-implantation genetic testing. They can decide to use donor gametes. They can decide to go for adoption. They can also decide not to intervene and just have the baby. So informed choice requires time, visibility, and support. So some of the people I've met in my work in the community have told us some things, and I thought it was relevant for me to include it here. So they've talked about how access is unequal. Someone said, I only found out my genotype when I became pregnant. And we've seen that a lot in practice. I can't get easily tested at my GP. So some areas that don't have like specialist sickle cell centers find out that they are disadvantaged. Why is something so important so hard to assess? We also find that knowledge is inconsistent. Professionals who understand sickle cell are limited. And what if I get the wrong person? I don't feel confident that everyone knows what they are talking about. I get different answers depending on who to speak to. They also talked about how options are not visible. So some of them don't know that pre-implantation genetics is an option. Even though I'm scared to tell them that they are only offered one cycle. That I learned from one of my colleagues, and I was in shock. So they only offered one cycle of the IVF. And of course, if you've had a first child that is not affected, then you don't qualify for it. Someone said no one explained prenatal diagnosis until it was too late. Why is there no other option for an affected fetus? Why is it termination that the only thing people talk about? And there's also the issue of values. I don't want to terminate the pregnancy even if the baby is affected. I want information, not pressure. I want support to prepare, not assumptions about what I will choose. So late information is not informed choice. It is just structural inequity. So what can we do in primary and community care? We can ask earlier about family history and non-hemoglobin variants. So I just wonder, and I know it is really rare for you to go to your GP and see a poster talking about sickle cell disease or see a poster talking about thalassemia or any of these other inherited conditions. What if we have that in our GP surgeries? Offer screening at the first opportunity. Do not wait for pregnancy. So people coming in, they're registering in their GP. Does the GP ask them, oh, what's your genotype? Do you want to be tested? Where are you originally from? Make genotype visible in their medical record so it informs future care. Refer promptly when both partners are carriers or one has sickle cell disease. Revisit conversations during routine reviews and transition appointments. Of course, we need to involve men in screening and counseling pathways. Embed pre-conception discussions into everyday practice, and signpost trusted, culturally relevant information to reduce fear and misinformation. So small practical actions taken early can help prevent missed conversations. So returning to our case, she made an informed decision, even if it's not the decision we wanted, but it is her decision, and she made an informed decision. Her baby is loved and wanted. She started treatment for this baby early, and we're quite happy she's engaging with care. So what stayed with me in this case was not her decision, but the timing. So when did we give this information or that you could do prenatal pre-implantation genetics? And we're having preconception conversation in the postnatal period. So that's the gap. So Preconception Precision Health is about moving that conversation from after the baby is born to long before pregnancy begins, as long as I stress the long. It's not about preventing babies with sickle cell disease. It's about preventing preventable gaps in information. So what I want you to take back from this talk today is that we need to be identifying early, optimizing care early, and supporting early. So preconception precision health starts with you and I. So we can't change the genes, but we can change when people receive the information, that shapes their choices. We can change what they do with this information. The earlier we give them the information, the better. Okay, I try to put this slide in here just to encourage blood donations. So it is something that I like talking about. We need blood donors all over the world because treatment for sickle cell disease requires a lot of blood transfusion. Yes, and that is me. Thank you.
Good afternoon, everybody, and it's really nice to be here. I know that I'm sort of last before lunch. I've got a train to catch, so I think we just need to crack on. But it's really great to be here, and my sort of topic really is about, we're all signed up, aren't we, for shaping healthy futures, but really thinking about preconception care, community health and genomics with health visiting. So I am a health visitor. I'm also an adult nurse and paediatric nurse, and went into health visiting after careers in both. Health visiting, for those of you who may not know, come and talk to me. I can kind of explain it, but we have a kind of key public health role. Today, what I really want to do is think about preconception care in health visiting, thinking about in the community health, population health, where do we fit in? And what role do we have with genomics? We could be here a while, I feel, but we'll keep it short. I think it's quite important to conceptualise, this is a global issue, isn't it? And our World Health Organization, known as WHO, defines preconception care as providing biomedical, behavioural and social health interventions before pregnancy occurs to improve health, modify behaviours and environmental influences. And I think we've heard that very clearly. But, that's back in 2012. Some of the language that we see in these policy documents do now seem quite dated. We do talk about men and women's health, and perhaps for some of us that may feel a bit uncomfortable. But, I think it's good to conceptualise where kind of this has had some origins from. So I know we've talked a lot about why it's important, and just to flag, who continues to flag how important the maternal-paternal health is, and the impact potentially on the risks of prematurity, low birth weight and birth-related conditions, which could obviously affect that baby. And then NICE continue to expand that. I found NICE actually very, very helpful when I've tried to be thinking about my role as a health visitor. So preconception care is a public health challenge. It impacts future health for parents and their children. It's about improving the general health of the population through increasing knowledge of healthy lifestyles, which should be an underlying philosophy, government says, for health, education and social care. So we're not alone here, are we? This is a big issue that, in a way, every sector is tasked to address where they can. So it's highly relevant for population and individuals who may conceive at some point in the future, as well as for the period when pregnancy is being considered. Quite stark statistics that go back now to 2018, but actually when you speak to colleagues such as Professor Jenny Hall, they're not any different. So we know that 45% pregnancies and 33% of births are unplanned, and that has a big implication for women and also children. So where can health visitors support? We are probably a most privileged professional group of nurses and midwives who actually, through the commissioned programme called the Healthy Child Programme, actually see families across their life course. So we work with families from the antenatal period through to that child starting school. We then hand over the baton to school nurses. So protecting health in infancy, supporting the transition for parenthood is vital, as we know that what happens in pregnancy and early childhood impacts on the physical and emotional health all through to adulthood. You may have heard of the 1001 critical days. That's very specifically thinking about the importance of health for that baby, but we know that that starts with maternal and paternal health. So I've mentioned the Healthy Child Programme. This is where we are mandated to deliver a certain number of core visits. We are universal in that, so every child and family should have that Healthy Child Programme, whether you live in Birmingham or Southampton. As I said, it starts in the antenatal period. And our work is in communities and with communities. So Kate often reminds me, we are part of community teams. We may be 0 to 19, so we may have school nursing colleagues who, we work very closely with, but we also work across skill mix. So, we have differing professional backgrounds, but part of the skill mix may be community nursery nurses, maybe community staff nurses, maybe non-clinical staff, but we all form part of those teams. And as a team, often the reach into the community is really effective because people may live in those communities, really know the communities, and actually have a lot of sort of connections within the community. And I think that's really important for when we're talking about pre-pregnancy care, preconception care, to have that sort of ability to sort of engage. One of the kind of really important things about health visiting is that we tend to approach all of our interactions with obviously the mantra of making every contact count, but we're not a professional group that aims to go in and tell. We work with people in sort of relationship building, which I know is a goal that we all have. But I think when you spend time working with families across that child's lifespan in those, early 5 years, you do have opportunities to build up relationships, which is quite different. So really for us as health visitors, I think the focus is on that inter-pregnancy period. So yes, it's all about supporting preconception care, but really where we can, I think, be most effective is in that inter-pregnancy sort of role where, a family we may have started to work with, they've had a baby, and then perhaps they're thinking about a future pregnancy. So it's that kind of inter-pregnancy space. Proportionate universalism is something that we offer. It's a bit of a mouthful, but it was first termed by Professor Sir Michael Marmot, who you may have heard of, in 2010. So it's been around a long time. But essentially, it's about providing healthcare services to everybody. So the universalism is everybody, but the proportionate bit is to sort of tailor it to who needs it most. So we talk about offering a universal health visiting service, everybody getting the same, but then it being targeted for those that need it, perhaps a specialist, so mental health needs, a child with perhaps developmental delay, parents for whom they're subject to safeguarding procedures. And then there may be sort of more specialist roles. So some of my colleagues do work in the sort of specialist area as well. That may be mental health. Still being health visitors, but you can sort of see how everybody gets the same, but also is meant to be sort of mapped to need as well, which I think is also quite important when we're talking about preconception care. So I wanted just to, in this slide, in a way, paint a picture of kind of where I think we, as a professional nursing group, can be effective, and to sort of talk about these here. And maybe we'll take that kind of up later, but also to just give you a little bit of an illustration about, for those for whom actually we do have inequity, we're talking about the underserved groups. So health visitors can support babies, children and family understand the impact of their health choices, whether that's vaccinations, dietary choices, lifestyle behaviours. For those underserved groups that we still have that universal reach and expectation to meet, actually navigating the health system for an asylum seeker who can't speak the language, doesn't understand the hoops involved, make that much more difficult. The health visitor is there for them. We have to kind of go to and work with. As I mentioned, building relationships and having multiple opportunities to support health choices across the Healthy Child Programme. It's not a once, meeting. It's that regular sort of contact. For the travellers family that I saw a couple of years ago back down in Southampton, who, have quite fluid bases, that is more difficult. They see lots of different health visiting teams depending on who they travel with. or who they travel to. So these inequities do exist for these people who have got who are underserved because of their choice of lifestyle. Understanding individuals' hurdles to health. We know so much more, do we not, about the importance of climate impact, home environment, clean air quality. What is it like being a refugee who, for a period of time, maybe a year or two, is stuck in a hotel, can't cook, has to be provided for? These are things that actually really limit them and restrict their ability to become more healthy potentially. And then finally, I think a key role for us, but I have to say, as I've reflected, I wouldn't say I'm a genomics expert in any way, but I do know how important it is that we as a professional group are integrating that into our role. I think our role is about listening, being that really critical ear, adopting professional curiosity when people say things in those sort of conversations, and considering genomics along their journey. So one thing that the IHV did in 2022 was we had a test and learn project which was funded. And really this is just an example of being a little more intentional as a professional group. And the aim was to strengthen the provision of postnatal contraceptive advice and continuity between midwifery and health visitors. It had a steering group. It was co-designed by parents, subject experts and health visitors. We tapped into the team from UCL that Professor Jenny Hall was part of. We developed a scoping survey from health visitors to understand what happens in current practice, barriers, enablers, and their thoughts about how perhaps the role could be extended, particularly around the kind of sexual health, postnatal contraception. And then we also asked parents. And from that, we developed some training. Initially, there were 44 delegates. It's now gone to a wider audience than that. But just really highlighting some findings. The parents said they just had no idea that perhaps they could talk to a health visitor about preconception care, thinking about next pregnancies. The health visitors equally said, not too sure about it being our role, and we would need some advice about safe pregnancy spacing and some help to develop conversation confidence with brokering such topics. And also we need to know a lot more about contraceptive choices than we do. And we probably need some help to think about how we approach this, considering how we need to be culturally sensitive, aware of religious and diverse needs. So as a consequence of that, I've explained that we delivered some training, but we also developed some resources. These resources were sort of posters, but also they were interactive for people to sort of click. And they just gave them a little bit more information about perhaps what you could do by way of brokering some contact, talking to your health visitor, maybe when you see them after your baby is born for the new birth contact, or at the development review when your baby's a year old. And then for health visitors themselves, they had some written resources. They had a practical pack that they actually could take out with them in practice. And then there was an e-learning module. So some wider dissemination of this training has occurred, and we're hoping that that will go a little more like nationally. At the moment, it's just been within the North East. So really, as I sort of pull together my thoughts about health visiting and genomics, I think in this interpregnancy space, we could be very effective, or more effective perhaps, at supporting families for whom there may be genetic risks for future pregnancies. We can be more adept at having conversations, I think, for families where close relative marriage is practiced, and making some sort of joining the dots there a bit better. And I think also there is potential to be that ear that hears the conversations from parents when, as Jenny Hall said, we go in and have those conversations with parents, asking about them, how they are. Often people do, bring things out for themselves when they are given that opportunity, especially if we've got that relationship where, work has been done, perhaps across previous months, that people feel safe. But in conclusion to my perspective on the role of health visitors in all of this sort of work. I think, and it does sound a little tokenistic, there has got to be some better working together. I think neighbourhood health does offer opportunities maybe to join this up better. We mustn't lose sight of this being a person, a baby, a family, and the need to stick to personalised care. I think training is great, but we do need to bring it back to the family and asking their permission. I think some multidisciplinary training could be really helpful to learn from each other. And also, I know that there's a lot of work in the space around nursing and midwifery genomic competencies. And I think certainly for health visitors, we need to think about those in practice. So I hope that that will be a real application of those competencies to support, us defining our role a bit better. And there are my references.